Assistant Dean for Admissions at the University of Florida College of Medicine. He's also Professor of Medicine and a very active member of the Division of Hematology and Oncology at the College of Medicine. Dr. Lynch is a well-known and respected medical oncologist and educator. His presentation today is Human Lymphomas and the Promise of New Therapies. Dr. Lynch, welcome.
Thank you, Ed, and thanks everybody for being here today. I assume everybody can hear me well?
Yep. All
right, let's get into it. So yeah, New Horizons in Lymphoma. Let me tell you what I want to do today. I want to kind of, as a lymphoma doctor, and that's pretty much what I do, lymphoma and chronic lymphocytic leukemia. I want to walk through how a patient ends up coming to me. So everybody has had lymph nodes enlarged, or everybody calls their lymph nodes. My wife still does this just to annoy me. She'll say, honey, my glands are swollen. They're not glands, they're lymph nodes, and they're doing work for you, but she does it just to be fun. So how do people come to a doctor's attention? How common are these? We'll do a little epidemiology. I'm going to have to, unfortunately, torment you with the classification of lymphomas, but hopefully I have it in a way that will make it understandable. And then, and I'm going to, in honor of Dr. Wilkinson, turn everybody into amateur pathologists before the lecture is done. Okay, Ed, you okay with that? He's not responding, okay. So what is the difference between traditional therapy and targeted therapies? And then we'll talk about the basic classes of targeted therapies. And we're going to do this really in the format of talking about a couple of patients, which is always very helpful for me just to frame things. Let's get started. So lymph node enlargement is actually very common. The best study actually was done in the Netherlands. And in their system, 1 year, 2,500 people showed up to their primary care doctor because they had an enlarged lymph node. And if you just kind of walk through this with me, about 10% of those were referred to a specialist, or saying it another way, 90% were dealt with by their primary care doctor. Of those who were referred to a specialist, only about a quarter of them actually needed a biopsy. And of the people that needed a biopsy, only about a third of them had a malignancy, which is around 1% of the group together. So 99% of people that show up to their doctor with a lymph node are in fact have a benign process. This is the best picture I could find of somebody with a little nodule in their neck. That has a lovely name. That's called the jugular-digastric node. And then I said, where do they live in your body? So you guys, I want you to think about the number of times you've had these. So about half of them in the head and neck area. And about 3/4 of patients that come in with lymph nodes are in fact localized. There's one particular place. Under the arm they occur, about 14% here in the inguinal region, you see in the groin area. So about 3/4 are just one area, and about 25% are more generalized. Now the next slide is going to be fun. It's going to show you a very extensive list that I want you all to write down, and we're going to go later, of what causes enlarged lymph nodes. Basic categories: infection and all sorts of different kinds of infectious. Obviously where I have this is where I live here in the lymphoma world, but there are lots of other strange diseases with names like Rosai-Dorfman and Kikuchi's disease that can make your lymph nodes swell. In fact, I have a patient with Rosai-Dorfman that we're evaluating right now. And in a general history and physical, one of my favorite stories is cat scratch disease you've probably heard of. I saw a patient when I was a fellow who the pathologist told us, a very famous pathologist, that if anybody has cancer, this person does. But when we saw her and talked to her, she had been scratched by her cat, and with observation, this is before we had good diagnostic tests for cat scratch disease, her disease melted away and was clearly not cancer, but was rather reactive. So it's a pretty important distinction. Now, some clinical things help us. All of our young buddies, if you're less than 30, 80% of the people that come in are going to have something other than cancer. And the location suggests benign. If it's in the high neck, meaning up here around where you have reactions to infections of your throat. If they're soft, if they're mobile, perhaps most importantly, if they're tender, they're almost never malignant, because tenderness implies inflammation, and inflammation almost always comes from an infectious source. The size matters, less than 2 centimeters, and then you have some story. A patient comes to see me. One of my lymphoma patients will come in and say, "Doc, I had a cold last week and I got a little lymph node here." That's pretty sure just going to be a reactive lymph node. On the other side, people our age, if you about 60% of them that come in with a lymph node are going to have something more significant. The low neck area, that is right here in what's called the supraclavicular fossa, or right above your collarbone, almost never is a benign lymph node. How they feel, rock hard or rubbery. Y'all remember the super balls where you throw them up and they bounce really high? Okay, when I'm teaching medical students, that's what a rubbery lymph node feels like. And then a rock hard lymph node literally feels like a pebble under the skin. So a good clinician can actually make a lot of inferences from this. Fixed and non-tender means I can't move them. They're attached to the underlying tissues. Non-tender, of course, means they don't hurt. And then the bigger they are, the more important, and then progressive enlargement. So these are the kinds of things that we look at, and I see maybe a person once a month who's being sent to me because someone is not sure if they need a biopsy to go forward for their evaluation. In the world of blood cancers, lymphomas make up about half of them. Blood cancers includes myeloma and leukemia. But there are 81,000 cases of lymphoma, and let me break them down a little bit for you. So this is the latest data that I have. So in 2016, there were 81,000 cases, 8,500 Hodgkin's patients, and 72,000 non-Hodgkins. And that's the number of people diagnosed. The prevalence may be a term that's new to some of you. It refers to the number of people that are living who have been diagnosed with the cancer, okay? So we have almost 800,000 people who have lymphoma who are still walking with us and talking, and the number of deaths is relatively low compared to the number of patients because we do quite well treating them. But most people don't realize that they're among the most common malignancies. After the ones everybody thinks about: breast cancer, colon cancer, lung cancer, urinary bladder, and melanoma, non-Hodgkin's lymphoma lives right up there. A little more common in men than women, 40,000 versus 32,000, but farther down the registry for death because we do very well treating them. Now, what's well known in the medical world is that women live longer than men in every clinical trial. And what I'm going to do is, throughout the talk, I'm going to show you some examples of behavior that no sensible woman would be involved in that may explain partially why men don't live as long. Here's a guy poking an alligator in an entire nest of alligators. These are just to break up the monotony a little bit. So let's start with a case. This is a person who's 55 years old. When I met him as a patient, interestingly, when I was an intern, he worked up on the ward as a ward clerk. He's a few years older than me. And so he had noticed one day when he was shaving that he had a little lump in his neck, and he went to his doctor. They ended up doing a biopsy, and he had small lymphocytic lymphoma, which is low grade, and I'll explain what that means in a few minutes. At the time, his white count was also elevated, and what that meant was these tumor cells were also circulating in his blood. But the rest of his labs were normal, and he had no symptoms whatsoever. So my question to everybody: does he need treatment? Think about this just for a minute. A person comes in to see me, they've been told they have cancer, and I'm discussing just not treating them. Okay, that actually sounds a little counterintuitive to a lot of people. Let's think about that. Here's what his peripheral blood smear looks like. This is a normal peripheral blood smear. These are red blood cells. This is a platelet. Here's a couple of different kinds of granulocytes and eosinophils. These are the guys that fight infection, a monocyte. And this is a normal lymphocyte. It's actually a little bigger than it should be. The lymphocyte nucleus should be about the same size as a red blood cell. And you should have a distribution. Only about 20% of your cells should be this particular subtype. But this is the patient's smear. And as you don't have to be a pathologist to realize these are all looking the same. This is a large number of these lymphocytes. And so he has small lymphocytic lymphoma as well as chronic lymphocytic leukemia. These are basically the same disease. If it lives in your lymph nodes, we call it SLL. If it lives in the blood, we call it CLL. How do we classify lymphomas? Most of you are familiar probably with the concept of stem cells. They're very interesting. And in bone marrow stem cells, Dr. Wiener was actually, he and I worked together with stem cell transplant back in the years ago. But what you can do is I could actually pherese from a patient their mononuclear cells, and by a series of methodologies, get their pluripotent stem cells down into a tube that's about this big. I could then obliterate their bone marrow, return those cells to them just like a transfusion, and in a couple of weeks their entire bone marrow will be reconstituted. It has the source of all of the blood cells, red blood cells, platelets, white blood cells, etc. And this process of differentiation is perhaps one of the most beautiful and elegant things in all human physiology. Don't worry about the fancy names here. Well, I'll get to that in just a minute. But so if a pluripotent stem cell decides it's going to become a B cell, then there are just a series of interesting genes being turned on and off that take it all the way from the stem cell, which actually looks kind of like a regular lymphocyte, into what we call a pre-B cell, immature antigen exposure. This is an important cell actually for today. How many of you have had your vaccine? Raise your hand, your COVID vaccine. Okay, so when you got your COVID vaccine, what it was doing was it was running around, and these cells, you have about 10 to the 12th or 10 to the 13th different kinds of lymphocytes that are looking for targets, and it found the proteins on the target and began to manufacture antibodies. And the way it does that, it goes from here all the way to what are called plasma cells. And these are the guys that actually are myeloma if you have a cancer of this one. Well, our patient's lymphoma is from this cell group, and you might ask, how does that happen? Well, some kind of block of differentiation occurs in this machinery of the cell. So rather than these cells dying as they're supposed to, they end up with a prolonged life and then accumulate in the blood and in the lymph nodes. Does that make sense to everybody? Sort of? Okay, maybe. So we classify them by what stage they're in. Now, when I do my lymphoma talk for medical students, and they're all going to learn histology, we start off with a nice diagram like this. So this is a lymph node that would be about the size of the end of your little finger. And the lymph node, if you cut it in half and stain it, you have these areas here. This is called the primary follicle. This is the mantle zone. Each of these areas of the lymph node have a function in your immune system. And the reason we show people this is because when you look at a real case, which is actually a lymph node here, here's this follicle, here's this mantle area. And I'm showing you this because you're going to be able to diagnose a lymphoma when this doesn't look right. So let's go back to this one. Remember these nice orderly follicles all around the edge. This is called the capsule of the lymph node. And you have this nice orderly series of follicles right here. Okay, so when we think about lymphomas, many of you probably have family or friends who've been diagnosed with any kind of cancer, but it's always the same. The first is the grade of the cancer. And that's not A, B, C, D, F. That's how fast it grows. And so we typically in lymphomas think of them in 3 grades. Low grade, which are very slow growing. Intermediate grade, which grow at a middle rate. I'll show you what that looks like. And then finally, high grade lymphomas. So that's one area. In this cancer, I'm trying to understand in a patient what's going to happen to them based on the specific subtype they have. The next is called the stage, and this is an issue of where it lives in the body. So we do things such as PET scans and bone marrows. A patient might have a fast-growing, a high-grade lymphoma, but it might be only in one place. So it could be high-grade stage 1, early stage, or you might have a low-grade lymphoma that is involving the bone marrow, which would be stage 4. So these are 2 ways of thinking about the cancer. And once you've got that information, we try to estimate the prognosis. And when we're thinking of treatments for our patients, we always want to sort of balance the toxicity with the outcome. An example of why that matters. If I have somebody that has a curable disease, I'm going to be able to give them or willing to accept much more toxicity if I have the prospect of getting rid of the cancer, the lymphoma, and having them live a normal life. If on the other hand, we have a disease that is not curable, we're going to be thinking carefully about quality of life and making sure that they can live as long as they can, feeling as well as they can. Okay, so I don't know if you guys can hear this. Is that coming through? Everybody remember the movie? This is actually a slide from my medical school lecture that I'm going to give in 2 weeks to them. And I call this lecture The Good, the Bad, and the Ugly. The sad truth is most of them have never even heard of, let alone seen the movie. But when I talk to patients, they usually get it. And so this is sort of the 3 kinds of natural history, we'll call it. Let me show you what I mean. So now you're going to become pathologists. Here's a general rule in oncology. The more normal a cancer cell looks and behaves, the more it tends to grow slowly. And the more abnormal or different it is than its parent cell, the more aggressive it tends to be. So let's go back and remember this picture. Then you see these follicles, see how nicely arranged they are here? One of these is a follicular lymphoma, and one of them is a diffuse lymphoma. And for a quick acceptance back into medical school at your age, okay, which one is follicular? Dr. Wilkinson, are you there?
Left side. Sorry, I was muted.
There you go. And everybody knows that this one, so you just became amateur pathologist. So since normal lymph nodes have follicles, the reason this is cancer is they're so abnormally architecturally arranged. There's no pattern to the growth. Once you get a cell that's growing so effectively that it's obliterating these follicles, it's called a diffuse lymphoma. So a low-grade lymphoma, a slow-growing one, tends to be follicular and tends to have small lymphocytes. These diffuse ones with large lymphocytes tend to be much more aggressive. And here's an example. I wouldn't expect you to do this, but these large cells here are about 3 or 4 times a normal lymphocyte size. So this is a large cell lymphoma, and this is the most aggressive of the cancers, called Burkitt's lymphoma. You may have heard of it. And it's characterized, at least cytologically, by these vacuoles, these little holes around the nucleus. Okay, so we're almost done with our pathology, but just to give you, so when I'm trying to sit down and talk to a patient, and I go through this with them actually. So we have low grade, good, bad, and ugly, intermediate, and high grade. So the histology that typically is low grade is follicular small lymphoma. Now, the natural history is a very important idea to get in one's head, because long before we had treatment, these diseases existed. And so it has been, for years, it has been known that low-grade lymphoma patients, follicular or small lymphocytic, live many, many years. I put 10 up here just because it's easy for medical students to remember. But over the years, that number is probably now out to 20 or more that people live with the disease. On the other end of the spectrum, we have these high-grade lymphomas. Burkitt's is the fastest growing human cancer. It can actually double in size in 24 to 48 hours. A patient might tell me the story that they had a little lump under their arm that felt kind of like a raisin. Then 2 days later, it's an olive, and 2 days later, it's an almond. And then they're starting to get a lot of sweats and fevers. And this is kind of a medical emergency. These patients typically get admitted to the hospital for evaluation. But this sort of, rather than the diffuse that I showed you in the larger cells, without treatment, this is a disease that will kill you in a couple of years. The good news is natural history is no longer really what we do with these diseases, because I have so many different treatments at my disposal and these 2 categories, the intermediate and the high grade, are curable with standard treatment. Okay. This is the way I punish my fellows. These are the guys who are learning how to become medical oncologists. This is the more sophisticated version of how to classify lymphomas with 3 points. So I will not trouble you with this for now, other than to say, so the original good, bad, and ugly, low, intermediate, and high, was from a meeting in Lugano in 1982. And you can see SLL, or small lymphocytic lymphoma, which is what our patient had, is in this low-grade category. But as we've gotten more sophisticated over time, we have far more tools at our disposal to classify diseases. The number of diseases has increased. Here's a charming, what was called the real classification of B-cell versus T-cell disease versus T-cell NK. And in the most recent WHO classification, there are over 60 subtypes of non-Hodgkin's lymphoma, which is only so that it keeps people like me, lymphoma doctors, in business, because my poor friends in practice have a hard time keeping it all straight. Here's another one that explains why men don't live as long as women. I'm never sure how anybody got the idea that I could jump into my pants down here if the guy's holding it, but I'm sure that didn't turn out particularly well. Okay, so when we're going to make a treatment decision, how do we go about doing that? Well, I've already mentioned it based on the grade and the stage and the overall health of the patient. My job as the lymphoma doctor is to know as much as I can of all of the scientific information about the natural history, published trials, compared treatments one to another, and I'll show you a little bit of that before we're done today. But we also have to know the goals of therapy. Is it palliative or is it curative? Are we trying to control the disease, which is a new phrase that really has come about in the last 10 to 12 years, used commonly. Even if I can't make the disease completely go away, if I can stop its growth and let somebody live for many years, that's a win. And I don't know about you, but I have the opinion that common sense may be the least appropriately named substance in the world. And so sometimes I think we need to go around and start saying, hello, what are you trying to do here? Because sometimes we get so busy as physicians trying to get through the day that we don't take 2 steps back and ask ourselves what makes sense for this particular patient. Medical oncologists have a love affair with acronyms. And I could give you a lot more than are here right now. My friend Dr. Zumberg actually always loved promocytobomb because it sounded like you're trying to, mace the cancer with a bomb. So this was actually developed where I trained at the National Cancer Institute. But each of these refers to a combination of different traditional anti-neoplastic drugs that have been used to treat lymphomas. And I add this one on because this was a relatively recent player in the game, and it's one of the drugs that our first patient ultimately was treated with. Now, targeted therapies really have come about in 2000. I'm going to show you a little bit more about rituximab, but these are antibodies, immunotherapy, and then small molecules. I'll come back to that in just a little. But what's the difference? This is another confusing thing between targeted therapies and traditional drugs. Because if you ask, each of these drugs has a target. This stands for a drug called hydroxydonomycin. It inhibits an enzyme called topoisomerase 2, and it chews up DNA, and that's how it kills the cells. So it's not as if these don't have targets, but the difference is this. These were developed by throwing a drug into tissue culture and seeing if it killed cancer cells, and then if it did, seeing if it worked, and trying to figure out what the target was after you knew it worked. All of these, the target is identified ahead of time, and then the drug is developed specifically to attack a target. And that's the big difference. And as you might guess, there's a little more specificity and typically a little less toxicity with these than with some of these. Most of these kinds of therapies don't make you sick to your stomach. They don't make your hair fall out like so much of traditional chemotherapy does. So come back to our patient now. Bill is his name. So, watchful waiting. In low-grade lymphomas, multiple clinical trials where patients were either treated early, right when they were diagnosed, or those who didn't have any symptoms were watched, there's absolutely no difference in the survival. And one of the arguments in favor of watchful waiting, as you'll see in this patient that we're going to talk about, is the longer we wait, the more clinical trials become available, the more drugs become available, and the options to these patients become more plentiful. When I try to explain this to patients, my simple little metaphor is, if you're living in the woods and you know there are wolves in the woods, you don't want to use your ammunition until they get close to the house. And so the average time, by the way, that patients on low-grade lymphoma go without treatment is about 2.5 to 3 years. But importantly, 20% of people have not required treatment in 20 years. And I have a handful of those folks that I still look after myself. I've been here, believe it or not, 30 years. So Multiple options are developed while we're waiting. Traditional therapy, immunotherapy with monoclonal antibodies, combinations, transplant, and lots of other things. And so there isn't a single good therapy for a particular class of diseases. What I do when I see a patient is I sit down and we go through a laundry list with pros and cons, and together we decide what the best strategy is. So the first one, the first targeted therapy that was approved for the treatment of cancer is rituximab. And these are monoclonal antibodies. Now, just to remind you, an antibody actually is shaped like a Y. You'll see this little figure over and over again. And the part that's this part here recognizes a particular protein on the surface of a cell. In the case of lymphoma cells, that protein's called CD20. And then this tail end of the antibody has a bunch of signals that basically tell your immune system, come here and kill these guys because they're not supposed to be here. One of the ways, if you haven't thought about it, the cancers develop is they learn to evade the immune system. And so when I explain this to patients, I basically say it's waving a flag at your immune system to come get them to kill you. But there's other things you can do. The antibodies can have a direct impact, killing the cells. That's what apoptosis means. You can attach a radiation source to it, so it becomes like a smart bomb with radiation. And we have 2 products for lymphoma that do this. And then the other one I'll show you is a toxin drug. So you actually use this antibody as a Trojan horse to get the drug inside the cells, and it becomes a very specific kind of treatment. So what's rituximab? Okay, so it was the first one. So here's the picture of it, and here's the business end of the molecule that recognizes, we even know what amino acid sequence it recognizes on CD20. And so what it does, it attaches itself. An important thing, sometimes when an antibody attaches itself to a cell, it gets internalized. It sends a signal that brings it in the cell. That's not what you want this to do. And part of the reason CD20 was chosen as the target is because no matter how many antibodies attach to it, it stays outside the cell. And when it's outside the cell, then this part of it, what's the IgG subclass 1 immunoglobulin, is the one that sends the signals and draws in your immune system. There have been 20 years. It was approved in 1999, and we first started treating it. We had the privilege of being involved in the original clinical trials. And this is one slide to show you that in low-grade lymphoma, like the one our patient has, the addition of the antibody, and there were a couple of options in this one, compared to survival. This, you don't have to be a statistician to know that these patients are doing much better than these. This is how many patients have passed away. So very, very effective. And then in aggressive lymphomas, the same thing here. You've got, this is the monoclonal antibody rituximab arm. This is chemotherapy without it. I kind of like this one. I think these may be canisters that are helping somebody arc weld over here, and spraying at those probably isn't good for your health long term. Okay, so let's go back to our patient now that we're armed with a little bit of information. So he has small lymphocytic, which we said is low grade. His white count was elevated and he had no symptoms. So for 7 years, he would come in to see me a couple of times a year. We'd feel his lymph nodes, measure his blood counts, and he was doing fine. But sometime around 6 or 7 years, his lymph nodes started to grow and his white count started to rise, probably a subtle change in the biology of the cancer itself. And so we decided he needed to be treated. And there are 4 basic reasons that you would treat somebody with low-grade lymphoma. The first is if the cells are making cytokines, so they have fevers, night sweats, weight loss, something like that. You'd treat them then. You'd treat them if they had a huge mass that was going to cause a problem. You would treat them if there was so much in the bone marrow that it was crowding out the normal cells. And he didn't have any of those at the beginning, but what he did have is the 4th criteria, which is their doubling time is about 6 months, and we know we're going to have to do something about it. So we treated him with that drug, bendamustine and rituximab, and he had a very good response. And he went on several years, me seeing him. And this is where it got kind of hairy. So now he's 12 years into his disease. Remember, he was 55 when he was diagnosed. He'd been through several rounds of chemotherapy that I won't trouble you with the specifics, but his lymph nodes were growing, and I kind of broke out the big guns, which were what's called FCR, and usually has a great response. Unfortunately, all the drugs did in his case was eliminate the normal bone marrow. And when we looked at his bone marrow to see why he didn't have any platelets or white cells, it was 100% replaced with this particular low-grade lymphoma. And so he ended up in the hospital, and he and I talk about this when he comes in. Since I'm telling the story, you know it has a good outcome. That I wasn't sure we were gonna be able to get him through it, because he had Legionella, he had an Aspergillus infection, he had and one other one. And so these are all going on without any white cells to fight the infection. And so we knew that we would have to do something pretty quick to clear out his bone marrow in order for him to survive. So what do we do? Okay, so now we're getting into these targeted therapies. Let me just walk you through some decision making. On this side, we had already used these drugs, the monoclonal antibodies, 2 of them in fact. We didn't have an immunoconjugate for this particular disease. What I don't have time to cover today are these 2 things, but there wasn't any availability. But over here is where we get into what are called small molecule inhibitors. And the 2 that we have right now for CLL or SLL are called BTK inhibitors and BCL2 inhibitors. Now, just to let you know how weird and complicated this becomes, this is a simplified diagram of the biology of a lymphoma cell. Okay, I'm not going to try to repeat all these to you. I did count them up when I was going. There's 28 different drugs in various phases of clinical trial just in lymphoma trying to interfere with this biology of cancer. So let me tell you the story of the BTK inhibitor first, because it's pretty interesting. So it stands for the Bruton's kinase. And so General Bruton, or Colonel Bruton, was an army doctor in the 1950s who discovered that there were a whole group of kids who were getting serious infections. And they were of the same type. And so as our sophisticated methodologies allowed us to measure chemistries, he was able to show, and people after him, that these kids didn't have any immunoglobulins. And what that means is they didn't have any way to react to such things as COVID vaccines. They didn't have any kind of antibodies to fight infection. And if you fast forward about 30 years, it was discovered that there is a specific gene in this disease called Bruton's A gamma globulinemia, after General Bruton, that was either absent or mutated. And so if you follow me here, what's supposed to happen in a normal person is an antigen comes in, let's say like your COVID antigen that you have got it for, turns this machine on, it signals through this cascade, which then goes in and makes antibodies for you. Well, what was happening in these kids is one of the turnstiles was broken, so nothing was going on. Well, why am I telling you all this? Well, some pretty bright people at Long Island Hospital in New York started wondering, maybe patients that have, say, CLL or SLL have this particular turnstile going all the time, and it's shoving the disease towards increased proliferation, and turns out that was the case. So a series of these drugs, ibrutinib being the most commonly used, are used in CLL for this disease. And I'll tell you, it was really fun for me as a lymphoma doctor. And in 2013, I got to go to our international meeting. And if you want to get a nerdy group of people, 1,200 lymphoma doctors from all over the world qualify, I tell you. But it was pretty cool because this is when the drug was first being tested. And so on one side of the aisle, I was able to see all of the complex chemistry of how it binds to BTK and how it shuts down cells. Then on the other side of the hall in a different room was the first clinical trial in human beings who got this drug. And this drug, in patients who had had sometimes up to 10 or 12 different previous treatments and weren't responding, 60% of them responded to this single oral agent. And the FDA got this one right. It was approved within a year as a breakthrough drug. All right, so that's the BTK inhibitor. Now, and this is the signaling that I was talking about before. Now, the other drug is venetoclax, and its mechanism of action is very different. When you think about how cells develop into cancer, one of the things that you may not have thought of is your cells are supposed to die at sometimes normal physiology. Best example of that that's easy to see is in children who are developing in the womb. They have actual webs between their fingers, and a normal signal as they're developing tells those cells to die, so that you end up with no webbing between your fingers. And that goes on in your immune system as well. And much of that is controlled inside what we call the sort of power pack of the cell, or the mitochondria in the membrane. And there are these series of proteins called Bax and Bach. And then BCL2 is a signal that is often overexpressed in lymphomas, and what it does, it shuts down the signal for the cell to die, making it more or less immortal. And if you kind of process that a little bit, what you'll see is that will lead to an accumulation of these cells, and it's usually in low-grade diseases. So venetoclax is this charming little guy right here, comes in and binds to the BCL2, prevents it from preventing death, and thereby killing the cell. So these are the two drugs that I have at my disposal for Bill. And this is where the nuances and inferences are important. There was a lot more experience with this one, but there's a problem with this drug in that it takes a long time to work. In fact, when I treat somebody that has CLL, their white count goes up for about 4 to 6 weeks, sometimes as long as 3 months before it starts going down. And what I needed for Bill, because remember, his bone marrow is filled with lymphoma, I need something that's going to work right now. And so this is the drug that works almost immediately as soon as you give it. In fact, sometimes it works so well, it actually kills the cells so fast that you get something called tumor lysis syndrome, where the tumor cells are dumping things into the blood. So we started Bill on venetoclax in the hospital, and I will tell you, it took 3 weeks, but we were able to get him out of the hospital. And he took venetoclax for about 6 weeks, and then his blood counts dropped. He was off it for a year or so. He's been on it now for about 1.5 years back on it. He took a trip that I'll tell you about in just a minute. So here's the comparison, a clinical trial of venetoclax with the drug that he received before. And again, you don't have to be a statistician to know that this single oral drug with Rituxan was far better than the chemotherapy he got. And importantly, this subtle difference here is important. This is overall survival. This is the number of people that are still alive. So venetoclax and ibrutinib, I can tell you, have become the upfront treatments. And there's a date. Here's the same kind of data for ibrutinib compared to another oral traditional chemotherapy. So in multiple clinical trials now, every subgroup of people, regardless of their age, is best served by being treated with ibrutinib or venetoclax. So what happened? He started on the oral chemotherapy. His lymph nodes actually went away very quickly. So I knew it was working, but it takes what you may not realize, it takes 2 or 3 weeks for your marrow, even after it's cleared out, to have normal things come back. We gave him every kind of supportive care we could think of while he was in the hospital, including replacing his immunoglobulins. His fevers finally went away. And he was in Yosemite about 1 year ago doing a hike that I couldn't do because he's in much better shape than me. This is the part of how the beauty of these targeted therapies can be used. This may be my favorite because I could see myself doing this. Here's a guy who couldn't get to the top of his hedge, and so he got a nice lift. So he's got his riding lawnmower on top of a hedge. I'm pretty sure that's not going to end well. So let's do another case to sort of get another feel. And like I said, they'll be done at about 10:45. So stay with me. I know I tend to talk fast. So here's a young lady who's 40 years old, and she's getting short of breath and actually having some chest pain, cough, and fevers. She goes into a walk-in clinic. They give her antibiotics, and after a week, she's no better. So then she comes back, and on exam, somebody actually feels lymph nodes in her neck, just like we were talking about before. They're about 1 or 2 centimeters. They're non-tender, but they are fixed. They don't move very well. And then she's given a chest x-ray. And I realize most of you don't read chest x-rays, but you can take my word for it. This big round thing is not supposed to be there. That's a big, what's called a mediastinal mass. So that brings us to the other hand of lymphomas, Hodgkin's lymphoma. Because we have a little time, I'd like to tell you the story of Hodgkin's lymphoma. It's kind of fun. So Thomas Hodgkin's described the disease that bears his name in 1832. If you can imagine a world almost 200 years ago without any real medicine, this was the first time that pathologists were doing autopsies and got the idea that maybe we should put all the organs in one area, all the lungs in one area, all the livers, and he put all the spleens in one area. And at the Royal Society, he presented what he called an abnormality of the spleen and absorbent glands, which is what they called lymph nodes. The best thing about this, they still have the sign-in sheet for that. There were only a dozen or two people there, and everybody completely forgot about it. In 1865, Samuel Wilkes made the same discovery and presented it at the Royal Society, and somebody who must have been our age, who was there hearing Hodgkin's 30 years ago, I said, I think Hodgkin's actually described this. And so Samuel Wilkes is the one that called it Hodgkin's disease. So I always like to recognize him. One could say that was the last act of academic altruism. But here's what the lymph node looks like. This is a picture of the normal one again. And in the most common kind of Hodgkin's lymphoma, you get all this pink stuff, which is called fibrosis or sclerosis. So it's called nodular sclerosis type. And the famous cells, every medical student who's ever graduated from medical school knows what a Reed-Sternberg cell. This is one of the half dozen things that all medical students gather. And you see these big cells that have, this is a binucleate cell. I think it looks kind of like two fried eggs laid together, but these cells are the Reed-Sternberg cells. And if you see these cells in the setting I saw you, that's Hodgkin's lymphoma. And like I said, about 8,500 cases per year in the United States. They also have some special stains, and this one's important. This is a protein called CD30. And CD30 is expressed in these Reed-Sternberg cells. You can see the two nuclei here, but here's the important thing about CD30. CD30 actually, when antibodies bind to it, gets internalized. It gets brought into the cell. And hence, it makes it a good target for what you might call immunoconjugates, where you put a drug attached to it. You have lymph nodes throughout your body. And this is a nice diagram showing how many you have. You may not realize you have this many lymph nodes. They're all too small to feel. And as we stage patients with Hodgkin's lymphoma, we need to be able to see what's going on the inside. I've already mentioned that staging is important. And just literally for 30 seconds, back in the days where radiotherapy was the only treatment for patients with Hodgkin's lymphoma, the diaphragm was a very important divide because there's about a 1 or 2 centimeter gap in lymph nodes, and human beings couldn't have their whole body irradiated at the same time. So they would irradiate half the body and half the body, and then you could make them meet under the diaphragm. So that's where the staging came from. But if you have a big lump here in your neck is all, that's stage 1. If you've got disease in your neck and in your mediastinum, which we know that's stage 2, the question, is there any disease under the diaphragm? And so here is the diagnosis from her. The classic thing is these are supposed to look like owl's eyes, and I guess they do. And this is her biopsy. And so here is your PET scan. Now, when you do a PET scan, what you're doing is you're giving a patient a little bit of radioactive sugar. And that radioactive sugar accumulates in cells that are growing quickly, which cancer cells are. So these are all lymph nodes in her neck. This is the big mediastinal mass we talked about. And here are some lymph nodes under the diaphragm. There's the liver. So this demonstrates that there's disease on both sides of the diaphragm. But what we use today are fusion CT PET, and here's an example of how that helps you. So this is a CAT scan that you really can't see the lymph node here very well. But as soon as you fuse it with the PET scan, you can see it lights up really hot. And so there is a lymph node, and this lymph node has Hodgkin's lymphoma in it. And this is the big mediastinal mass here. Okay, so how are we going to stage this young lady? She has both sides of the diaphragm, so that by PET. And she has fevers, which came along, and that's part of what we call B symptoms. So she is stage 3B. And the question is, how do I treat this young woman? Okay, here's a guy apparently playing Harry Potter. Again, not sure how that's going to go. I don't know who took these pictures, by the way, but they're kind of fun. And people often send me this stuff because they know I like twisted humor. Let's go back to our little diagram about antibodies and what you can do. And here's the drug toxin combination. So at Seattle Genetics years ago, they developed an antibody to CD30, and they attached to it, this is a sort of a chemical link, this drug, which is called MMAE, and it is a microtubule inhibitor. It is a very powerful anti-cancer drug. It's not one you would want to give somebody intravenously because it would have too much toxicity. But if you attach it to this, it becomes a smart bomb. It finds the cancer cells that express CD30 and it gets internalized. So this is kind of what goes on. It gets internalized, it cleaves it, and then the microtubule, which are the guys that sort of help the cell communicate, are shut off by the drug. And it's very effective. In the original clinical trials, it was only used after someone relapsed from transplant, and 70% of patients responded to this single agent drug. So the question became now, well, we're used to using these targeted therapies at the end of someone's care. What about, can you improve on standard therapy for Hodgkin's lymphoma? So ABVD was the standard therapy for about 30 years for Hodgkin's because nothing was better. And just in the last couple of years, after a clinical trial, it was shown that this drug could not be given with this one. It caused too much lung toxicity. And so this is the combination that came up. And this is the outcome of patients treated with the targeted therapy. And that may not look like a big difference to you, but it is, and it's important. We cure most patients with Hodgkin's lymphoma, so every step forward is going to be a small incremental change. And this led to AVD-BR becoming the new standard of care in advanced stage Hodgkin's lymphoma. So what happened? Well, we gave her the drugs, and again, you don't have to be a radiologist. All that stuff is gone. She responded beautifully to it. She didn't even need, we used to give radiotherapy to everybody with big mediastinal masses, but she responded so well to the chemotherapy, we were able to avoid radiation, and she's been in remission now for over 6 years and doing quite well. Okay, so we're back to our classes. Just to remind us, I wish I had time to talk to you about all these things, but each of them, and I probably have already laid too much on you. So let me give you a few conclusions and we'll take questions. Lymphomas are a very treatable, often curable group of cancers. The standard therapy is still very important, and I want you to hear me. This, as long as it's going to be a long time before targeted therapy completely replaces standard chemotherapy, because we know it cures people. It's now we're really thinking in combinations. Immunotherapy of the sort we saw with antibodies is very important, often with chemotherapy. And then these new drugs coming online, I literally have patients who, when they relapse, a new drug is approved and I have something to treat them with. So it's a pretty gratifying thing for both me as a physician and I have the bravest, most wonderful patients in the world, which makes my practice a lot of joy. And I'll leave you with this final, this is one of my favorite bits of art. I love art and music. Anybody know the, it's called Ciencia y Cuidad. Anybody know the artist? Barbara, did you say something? It's a little atypical. It's a beautiful picture, isn't it? What you have is the physician here at the bedside, not staring at the computer, but at the bedside of the patient, holding her hand while taking the pulse. You have the family and the spiritual dimension of care here. This is actually a Pablo Picasso, one of his earliest. And many think it was autobiographical because he lost his mom when he was a young child. So with that, I'll stop and we'll take questions.
Many thanks, Jay. Maybe we can close your picture and we'll see everybody who's here.
Okay.
See who's raising their hand. There are a few questions in the chat. One person asks, is there any issue of lifestyle, diet, exercise, mental health as factors that cause the disease?
Fair question. Get this one a lot. So the only environmental factor that has ever been somewhat tied to lymphoma are pesticides, and just about everybody is familiar with the class action lawsuits that are being offered, suggesting that, sorry, move this out of the way, suggesting that, oh my goodness, what's the name of the weed killer everybody uses?
Agent Orange.
No, not Agent Orange. That one really does. It's a commercial.
Roundup.
Yes, exactly, Roundup. And so, but it's interesting, the committee that reviewed the evidence decided there's no evidence to support that the component of Roundup is the cause of lymphoma. It didn't stop them from suing class action. But in terms of lifestyle, diet, and things like that, what I tell people is anything you can do to make your body healthy is good for you and makes you a better candidate for treatment, but no specific thing has ever been linked to getting lymphoma. Does that answer it?
Yeah, that's good. And there was another question: is any source interested in funding studies such as that, environmental or other related effects?
Yeah, I don't know that I have the answer to that. Yeah, it's a good question. I just don't know if there are funding sources for.
And I see one other question about do specialists like yourself become involved with lifestyle studies or behavior modification for your patients?
We do have some. It's not really behavior modification, but we have lifestyle studies going on as part of the cancer center. And off my top of my head, I can't tell you what the questions are, but I know that those folks, we have investigators who ask if they can talk to my patients. And there's some about life that stop smoking. There's some about psychological support and things like that. I can't be more specific than that.
Right.
Anybody else?
Well, let me just say the progress that's been made on the B-cell lymphomas, and I know you've been part of that, is quite impressive because my brother passed away from a B-cell lymphoma, well-differentiated one. He lived exactly 7 years.
Wow.
So,
Well,
I have a question.
Sure.
It doesn't deal with lymphoma, it deals with your cartoons.
Okay.
Do you think that men are stupid? More stupid than women?
I think that's an excellent question. I would say that testosterone does blunt certain areas of the frontal cortex that might make us somewhat disinhibited. How's that?
Okay.
well, sometimes it's ethanol related.
And I got a whole series of those. Yeah.
Ken Burns, go ahead.
Yeah, just a specific question. You didn't mention Gleevec in association with any of this. Could you say anything about it?
Yeah, Gleevec, for everybody else, for the series, we're so subspecialized now that I'm the lymphoid doctor, but chronic myelogenous leukemia is a myeloid disease, and so I have colleagues that take care of them. It was the first small molecule targeted therapy for cancers, and it was CML, chronic myelogenous leukemia, used to require sometimes stem allo transplant to treat them. But a particular translocation, what's called the 922 translocation, which is specific for that disease, creates a protein against which a specific drug was designed. And it also, in its phase 1 trials, was remarkable and quickly replaced all the more toxic therapies for CML. We now have second and third generation TKIs in CML. For people that become resistant to one, they actually will respond to another one.
All right. Jeannie Walter has a question. Jeannie?
Again, I'm like the other gentleman that I just have a comment about men not living this long. Is when I was at the Grand Canyon a number of years ago, somebody had fallen off one of the viewing areas 2 weeks before I got there. So I asked one of the rangers how many people a year die at the Grand Canyon, and he said between 8 and 12, and most of them were males from 19 to age 30.
Yes. Everybody knows the most famous last words of young men, right?
Right.
Hey, watch this.
Yeah,
Hold my beer and watch this.
Right.
This is true. All right. Do we have any other questions? Paula Crowley has a question. Paula?
Yes, terrific lecture. I was wondering, so the rate at which we're developing new cancer drugs and specifically monoclonal antibodies, would you say that the monoclonal antibody approach is the dominant drug therapeutic approach right now, or do you see additional types of therapies coming our way?
The answer is both. For instance, in diffuse large B-cell lymphoma, which is the intermediate grade most common, antibodies are the epicenter of most of investigation, and small molecules are still kind of working their way in. In the low-grade diseases, we still love antibodies, but we have more and more of these oral compounds. So if I had to predict the future, what I'd say is there will be attenuated traditional chemotherapy made better with antibodies and possibly maintained or kept in remission with some of these oral compounds. That's my guess.
Okay, thanks.
Well, I don't see any additional questions. Jay, I think you've done a remarkable job. I want to thank you for coming and talking and helping us all appreciate this illness a little better. And also wish you every success in